welcome everybody to the Carcinoid Cancer Foundation's Facebook Live series. We're happy to see you again. My name is Rain Bennett. For those that aren't familiar with me, which now you've seen my face just about every week, so maybe you're familiar with me. If you're not, I'm a filmmaker, a documentary filmmaker, and video producer that's been working with CCF for almost a decade now, creating video content to help spread the awareness and educate people on neuroendocrine tumors and treatments and how to navigate this net journey, if you will. We're very excited about this program and the impact it's been able to have and the reach that it's been able to have. This is something that's been really fulfilling for us. So we're glad to have you here for this virtual one-on-one session with a specialist or a doctor. So if you are signing on, as I see our numbers are increasing, I always love to ask where you are signing on from in the world. I love that these reach all over the world, and we kind of position them at a time that we can hit up the West Coast, and we can also reach our friends overseas in Europe and other continents. But let us know where you're signing on from in the world. We'd love to hear how far we're reaching. We want to thank our sponsor, Lexicon Pharmaceuticals, for their support and really making this COVID-19 Facebook Live series happen. Today, our guest is Dr. Amr Mohamed. Doctor, how are you?
How are you doing, Graham? Thank you so much for having me today.
Yeah, we're very happy to have you. For those that aren't familiar with you that are attending today, could you let us know a little bit about your background and how you ended up serving the people in this community of neuroendocrine cancer?
Yeah, absolutely. So after I finished my medical school in Egypt, I came here in about 2010. I did my research fellowship and most of my training between Atlanta, Georgia, and Michigan. I think I was very lucky during my training to be working under one of the most well-known net experts in the country, including Dr. Farah Phillip, Dr. Anthony Shields, and Dr. Strasberg. So it was a great experience and knowledge about neuroendocrine tumors. And the most thing that really get me attracted to neuroendocrine tumors is most of them are very complex, unique cases. And most of them really need a multidisciplinary team to treat them. So the idea of having only a net specialist, I don't think it's not enough anymore. It's not a one-man show. And that's what really attracts me to come here at Seidman Cancer Center at University Hospital, Case Western University in Cleveland, Ohio, where we really have a group of, net expertise working together from surgical standpoint, medical oncology, pathologists. We're very lucky to have Dr. Selby Asa, one of the pioneer pathologists for neuroendocrine tumors, interventional radiology, and even nutritionists and endocrinologists. So I think it's a privilege to work in this unique type of disease.
Yeah, and I have to plus one that about the multidisciplinary teams. In fact, we at CCF have realized how important that aspect is, that one of our videos that we're releasing in the upcoming year is focused on that. So we've been talking to a lot of doctors about how important having that multidisciplinary team is to this particular disease. So absolutely. So for everybody that's signing on, welcome. I see we're getting some thumbs up, so people seem to agree with us there. Again, let us know where you are in the world. Today, we're going to talk about, again, COVID-19, your health and safety as a net patient, and what that means. We're in a unique position now because we're starting to see things tilt back right side up where people are starting to reopen their economies. And so the conversation is a little bit different than it was a month ago. Okay. We still have concern from our net community of like, well, what does this mean for me? Like, am I able to go out? And so this is what we hope to address today. So please go ahead and start sending in your questions about that topic. Please know that Dr. Mohamed can't really answer very case specific questions. So we'll try to answer if it's too case specific in generic terms and try to give you some help. If you're attending, go ahead and rephrase the question for us. We'll try to, keep that conversation with you. And if we aren't able to answer your question directly, I always encourage you to follow up with CCF either here on their Facebook page or carcinoid.org, their website. So go ahead and send in your questions. If you have general net questions, Dr. Mohamed, are you okay taking some general questions as well?
Oh, definitely.
So if you have those, we are still sticking to COVID-19, but it's understandable that people have different concerns. So we'll give priority to coronavirus questions first, but go ahead and ask your questions if they're general net questions too. And if we have time, we'll try to get to them. Before we move forward, quick disclaimer from our sponsors and our legal team. We just want to say that the opinions expressed by the guest presenters, that's Dr. Mohamed, as well as the questions asked by the audience, that's you all at home, have not been created or suggested by the sponsors of the Facebook Live program. CCF doesn't endorse or promote any of the views, opinions, or information in this provided in this presentation. And audience members should rely or should not rely on the opinions or information expressed by the guest presenter, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health and treatments. So that was a lot. It was a little wordy. It always is with disclaimers. But let me translate. It just means that we're going to give you some general advice today to help direct you on this journey. But by all means, discuss any decisions that you want to make about treatments moving forward with your team that you work with that know your case. Would you agree with that, Dr. Mohamed? Anything to add to that?
Yeah, sure.
Great. Okay, so we've got some questions already coming in. Continue to send them, and we will get to them as we go forward. So there's a few questions that I'm going to kind of lay the groundwork and the foundation up front with Dr. Mohamed, just because I've realized we've been doing these for a few weeks, and I realize some of the general concerns a lot of the NET community has. And so I want to go ahead and lay that foundation. Now that some of the restrictions are being lifted here in North Carolina, where I live, we're in phase 1 starting tomorrow. Are there any recommendations that you have specifically for NET patients now that retail locations are starting to open up and restrictions are being lifted?
That's a great question, Rain. So dealing with COVID-19 or coronavirus, it's having a lot of unknown to all of us, as the physicians, as the medical professionals, and the patients as well. So I think we're starting very concerning in the beginning because we're still concerning because we don't know a lot of information. But definitely going with specifically neuroendocrine tumor patients, the main question I keep getting often, I'm really having a higher risk for getting a COVID-19 or coronavirus infection. And my answer is, it depends. It depends what is the patient status, what is the comorbidity. It depends where is the patient is geographically in the states. Some states are very hotspot for coronavirus. Some other states are not the same. In general, I say the NET patient, they're having the average risk of getting coronavirus like any other patient. Cancer patient in general having a little bit higher risk of complications and what we call the immunocompromised immunity, which means the cancer by itself can affect the immunity of the patient, can invade the bone marrow in some cases, affecting the production of the white blood cell, which is the first line defense against infection. And also some of them having poor nutrition. So cancer itself, it's a condition or comorbidity that can put the patient at higher risk. The NET patients are in the low spectrum in this area. If the patient is not having chemotherapy or any medication affecting their immunity, I think they have the average risk in getting COVID-19. There are some specific neuroendocrine tumor patients with certain neuroendocrine tumors in the lung, or they already having chemotherapy. This patient can have more risk of getting complications from chemotherapy and getting more high risk to get COVID-19 or coronavirus. So the main recommendation for them to have this going with the same CDC guidelines to keep a physical distance, to wash your hands, always more than 20 seconds, and to use hand sanitizer, 65 or 70% alcohol. This is the general recommendation that I give for all my patients. In addition, every case, we have a specific recommendation for hopefully decreasing the physical impact and the unnecessary visits for our cancer center, for example. Now, hopefully, it's getting better slowly. During the last week, for example, I'm talking about Cleveland, Ohio. Mm-hmm. We're having more like a plateau in the curve, and actually we're seeing more decrease in the cases as well. So we start opening the elective surgeries, for example. We're starting very aggressively with telemedicine in the beginning. Now we're having more and more patients coming to our office. Again, we're taking all the precautions. So if the patient in chemotherapy, more immunocompromised, older age, I rather these patients to continue doing telemedicine. If the patient having the average risk, we're starting being more flexible for getting this patient. Again, having a mask, I think it's very important, keeping the physical distance, and we use all the sanitation that we use to prevent the infection.
Thank you. I appreciate that. And for everybody at home, we always like to know if these answers and if the information we're presenting is providing value. We're here for you. This is why we're doing this. So if you like an answer, or if there was a question of yours that was answered and you appreciated the information, just give us that little thumbs up or a heart emoji down there at the bottom. It's just a real simple way to let us know, like, hey, thanks, that was good. I needed to hear that. So we'd appreciate that moving forward. It lets us know that it's resonating and it's working for you. Dr. Mohamed, what factors should NET patients consider to determine whether or not to have treatment still in the next few months? I know you talked about, elective surgeries are starting to open up in your location, but if I'm a NET patient, should I still be hesitant to schedule treatments?
I think it's a great point. It depends. It depends where is the patient located at. For example, if a patient located in a state which is a hotspot like New York or Washington, and if the patient has some comorbidities which can put them at higher risk of getting complications from coronavirus, like they are older age, they having diabetes, cardiovascular problems, some lung issues, it depends. This is the factor that I'm looking at for the patient and the state. But then what is the neuroendocrine tumor disease that the patient has? If they're having the lower grade neuroendocrine tumor, they mainly will be in somatostatin analog, which is not immunocompromised treatment. I think this patient, we can still either delay the treatment or even space it out with the increasing of some doses. We do that all the time. But if the patient have more the higher grades and more aggressive cancer, we need also to see what is the benefits and risk. I think my whole point here is that the patient needs to talk to their oncologist. Is my disease can wait for a couple of months, until I get the treatment? Can we delay the treatment? Or I really have an aggressive higher grade tumor, which I will not be able to wait. When it comes to surgery, I think elective surgery, it also depends. If the patient, we're doing surgery because they are symptomatic, and we do what's called more cytoreduction or palliative treatment to help them with the symptoms, I don't think this patient would be able to wait a long time if they are really symptomatic, or if they have a high tumor bulk and we need to do this type of surgery. But if it's more elective surgery, the patient does not have any, for example, small bowel neuroendocrine tumor with no any bowel obstruction, and we do it more as an elective surgery to hopefully reset the clock and improve the survival. Definitely this patient can be delayed until it's becoming more stable. So the patient should put in the mind, what's my grade of disease? How aggressive is my disease? Where I'm located, is my hospital that I'm getting the treated at, and the state is very hot spot or not? So all these factors should be discussed between the patient and the oncologist.
I think that's such a great point about where you're located. We were just talking before we started the live that here in Durham, North Carolina, it's okay. I mean, we do have some deaths in some cases, but nowhere near compared to some of the larger areas. I had a quick question, or maybe we could establish a little bit about the differences between a high grade and a low grade NET, because that's something that I know a lot of people are interested in learning more about. We're making some video content about that topic exactly. And I know it can be a little complicated, but can we establish some of the differences between what's considered a low grade NET and high grade?
Sure. So when the patient comes to me in the first time, I always try to visualize for them what's neuroendocrine tumor first. What do you understand about neuroendocrine tumor? And the first thing comes to the patient's mind, what is the stage of my cancer? And this is one of the most critical, important information for all the cancer. When it comes to neuroendocrine tumor, we have other information which is also the same as important as the stage, or even more important. And this is called the differentiation and the grade. Differentiation, not to use a medical terms, meaning how is these cells of the cancer looking like comparing to the normal cells? If they almost looking the same with some differentiation and differences, we call it well differentiated. If it is looking completely different with most aggressiveness, biological behavior, and like biological behavior and how they looking like, especially under the microscope. That's what we called poorly differentiated. Poorly differentiated usually is the most aggressive type of neuroendocrine tumors. All my patients will need a chemotherapy in most of the times for treating this type of disease. Well differentiated is most of our neuroendocrine tumor patients that we see every day. And there are three grades. And grade, what's the difference between differentiation and grade? Grade is how fast are these cells multiplying. And we basically use some parameters, including something called a Ki67 and mitotic index. If we still remember from our biology in the high school and all that, the mitosis is how fast these cells multiplying and dividing. And the grade 1 is considered the lowest grade. Grade 1 and 2 still considers them, both of them are the lower grade. Grade 2 is considered the intermediate one. And then grade 3 is the most aggressive one of the well-differentiated. So this is what we mean by low grade, well-differentiated, high grade, well-differentiated, and the high grade, poorly differentiated neuroendocrine tumors. When it comes to the lung or the bronchial carcinoid, we basically having almost the same. The lower grade, we call it typical bronchial carcinoid or typical lung carcinoid. And when it comes to the intermediate and higher grade, especially if you have some manifestations under the microscope, including necrosis, we call it atypical bronchial carcinoid.
Dr. Mohamed, I got to say, I talked to a lot of NET specialists and doctors about this topic, and that was maybe the clearest it's been explained to me. So personally, I just went and I liked it. I gave us a heart on our own Facebook Live because personally, I really enjoyed that answer. Thank you. That was so clearly laid out. I appreciate that so much. So I hope that helped some of the people understand the difference, because that's a point I think a lot of people are really unsure of, and they don't understand the difference in grade compared to type or stage of cancer, like you said. So thank you for taking the time to do that. So we've got some questions coming in now, which is great. Continue to send them, everyone listening. So I'm going to go ahead and go to that, and I'll tell you who asked them, and we can kind of address that person specifically as we're asking this. So Madeline asks, what can carcinoid syndrome patients do to reduce the severity of their symptoms while they are sheltered in place and can't go in for octreotide suggestions? And I think it's Madeline.
What's the patient name again?
I believe it's Madeline or Madeline.
Madeline. Okay. So that's a great question, Madeline, actually. And we getting this question from starting, I think, end of February, when everything starts to get, a little bit scary for all of us. If I'm giving a patient somatostatin analog, and somatostatin analog is the broad name of the injection. We have the octreotide, or what we call sandostatin, which is a long-acting octreotide, and we have lenalidomide or somatinib. Both of them almost the same, medications and the same mechanism. One of them is intramuscular, the other one is subcutaneous, which is under the skin. Usually we use this medication to have two goals. The first one, to control the growth of the tumor, what we name a delay progression of the tumor. The second thing, to improve the symptoms that the patient has, what we call the carcinoid features or carcinoid symptoms. So if the patient is taking the medication to improve the symptoms, my advice, you cannot stop the medication. So what I can do, I'm really concerned come to the hospital, being exposed to other patients. We have a lot of options for you. Number one, you can take the injection near to your house. If you have a satellite cancer center associated with the main cancer center, we can usually send you near to your home, and that will be easier for you. We can always space out the time of the injection and increase the dose. Usually we can do that as well. But now I'm really glad that you brought that up, because the two big company which is providing this type of medications, they now having what we call mobile or home injection program. So basically we can always, that's what I'm trying to do now for the last month, trying to switch most of my patients, especially the older patients who having other comorbidity, which is the higher risk spectrum, that we can do a home injection. We can basically fill all the information for the patient, contact them with the pharmaceutical company. They still need to talk to their insurance and see that's covered or not. So taking the injection at your home and follow up with your insurance company definitely is very important Talk to your oncologist to see if you can space out the injection and increasing the dose, and also see other options by taking the medication hopefully near to your house. If we give the medication mainly to control the growth of the tumor, and it's not basically for symptoms, we can talk with our patient to hopefully delay the treatment. There's no any problem with that, especially if he has the lower grade, and most of these patients on somatostatin analog are the patient with lower grade and does not have a high tumor burden or does not have a lot of tumor basically. So this patient very, very reasonable to delay the treatment and give them some break from the treatment if they don't have any symptoms.
Awesome. Thank you. Appreciate that. Next question, Sharon asks, and we touched on this very briefly, but I'd like to again. Sharon asks, if I had a lung net removed in January, so pretty recently, am I vulnerable to COVID-19? A lot of people with lung nets or dip neck are concerned about this because it's a respiratory disease.
That's a great question. Again, getting or having neuroendocrine tumor by itself is not putting you really at higher risk of getting coronavirus or COVID-19. However, if you have a bronchial carcinoid or lung neuroendocrine tumor, number one, you will have some manifestations and symptoms will be similar to the coronavirus in some way for the patient. Coughing, respiratory distress, wheezes, stuff like that. So this by itself is concerning for the patient, though I have the symptoms of coronavirus. But also this patient may be having a higher risk of complication if they got coronavirus. Because if you have a surgery, they remove part of your lung, there's decrease in the lung capacity, this can put you at higher risk of getting complications. So to make it in one line, no, you are not at higher risk to getting coronavirus. You should have the same precautions, keep the physical distance, always cleaning your hand. Try to be away from anyone who you don't know who you may be infected or not. Some people does not have the symptoms of coronavirus and they still can give you the infection. So this is my recommendation for the general precautions. But for the complication, yes, if someone had neuroendocrine tumor of the lung and they got coronavirus, they may have more or higher risk of complication due to decreased lung capacity, due to the cancer in the lung, and that's very reasonable to mention that.
Great, thank you. So next up, we have a question from Aaron. And we've talked a little bit about treatments. Aaron is asking a question about Lutathera, and for those that aren't familiar, that's PRRT. Is that correct, doctor?
Yeah, so Lutathera or radionucleotide therapy. Yeah.
Right. So Aaron asks, have you started treating patients with Lutathera now that COVID-19 seems to be slowing down? So we talked about treatments a little bit, but specifically about PRRT.
Sure. So PRRT or peptide radio receptor nucleotide therapy, or what we call Lutathera or lutetium-177, it's one of the novel treatments that we have in the last couple of years, basically attaching the somatostatin analog, the same injection that we give you every month, with a radioisotope. And that's helping us by giving a very targeted radiation to the neuroendocrine tumor cells who are expressing the receptor, somatostatin receptors. So one of the most common side effects of this treatment, it can affect the bone marrow, especially the production of the white blood cell, what we call lymphocytes, which is fight the viral infections. And the patient usually telling us, the old patient who already started the treatment, should I delay the treatment? Should I still come for my treatment? We see some myelosuppression, and this puts you at higher risk of getting more complications from the infection if you got it. But in the same time, you have a cancer, which is most probably progressing. And this is the reason why I started Lutathera. Because Lutathera is approved as a second line after the patient got progressed on somatostatin analog. So if the patient does not have a lot of comorbidity and is not old age, does not have a lot of other risk factors, we usually resume the treatment. We don't need to delay the treatment more than the 2-month period between injections. And we take all the precautions. We have our screening, again, the social distance that we have and physical distance, cleaning the hands, using the hand sanitizer, make sure that every precautions we take between patients to prevent transmission of the infection. If the patient is coming new to me and asking me, should I do that? It depends. If the patient have a lot of tumor bulk or tumor disease and need to be treated sooner than later, and does not have a lot of other comorbidities, they are not very old in age, I think it's reasonable to start the treatment and take all the precautions that we talk about. But if the patient having maybe less disease and maybe other comorbidity, and they can find another treatment option like targeted therapy, or even delay the treatment a little bit without affecting their benefit, it's very reasonable to have this conversation with your oncologist and maybe delay the treatment 1 or 2 months until you can start after everything is more stable and getting better in your state. So it's always conversation between you and your oncologist, keeping in mind where you're living. If you have a lot of comorbidity, what is the tumor burden or the tumor bulk that you have? Do I have any other options of treatment that we can delay the Lutathera or the PRRT for them? In our institution at Seidman, we start treating the patients again the last couple of weeks, actually. We're taking all the precautions. Our old patient, we did not interrupt any of them because we think that the benefit will be more than the risk of delaying the treatment more than 2 months. And I think in the coming weeks, we're getting more and more new patients. We are going to treat them without any delay.
Got it. Thank you. Okay, hopefully that helps, Aaron. So for those that are just joining us, I see our numbers are continuing to grow, which is exciting. We really love to see that. Again, I'll ask, let us know where you're signing on from in the world. If you are just signing on, we'll try to get to your questions, but please know that we may have already addressed it. So I may refer back to hey, go back and watch the beginning of the video. And if that's something that you need to do or want to do, know that this is live, but it's going to live here on the Carcinoid Cancer Foundation Facebook page, so you can always refer back to it, okay? That being said, if there's anyone that you think would benefit from this now that we are going live, go ahead and tag them in this in the comments or share the video to them. And if they aren't able to make it, then please let them know that that it will live here on the Facebook page, and they can always come back and see all these great bits of wisdom that Dr. Mohamed is laying out for us today. So we've got just a little more than 30 minutes. We're about halfway done with Dr. Mohamed and his time today. So go ahead and send your questions in. Dr. Mohamed, I've got a few general net questions now that I'm going to pivot to, if that's okay with you. And everybody else out there, just another reminder, if you are enjoying this and getting some good value of it, send us a thumbs up or send us a heart emoji and let us know we're doing a good job. That's what we're here for. Okay, so Dr. Mohamed, Patricia asked, I would like to know why Lanreotide causes weight loss and hair loss. Is that true, first of all? And if so, can you speak to that at all? I'm unfamiliar.
Sure, that's a great question, Patricia. So somatostatin analog, including Lanreotide or Octreotide, having a very common side effects, mainly of the GI, include bloating, gas, abdominal cramps, pain, and even increase the risk of the gallbladder stones. There is some case reports and very, very rare other side effects, including hair loss and including weight loss as well. That's actually even less than 3% of the patients. I have a couple of patients having the same side effect. But usually that's not common. And usually it gets better, actually, if the patient, for example, switch from somatostatin analog and he starts something else. If he's progressing or she is progressing, we start targeted therapy or other treatment. Usually this hair thinning and the weight loss is getting better slowly after that. So overall, it's not a common side effect, but it happens. We see it, and there's some case reports about it as well. Unfortunately, there is nothing really you can do to prevent that. But for the weight loss, I think it's a very good point. So when you go to a neuroendocrine tumor cancer center, specialist cancer center, you need to know that there is a specific nutritionist who can meet you from day one to talk to you about the proper nutrition for neuroendocrine tumors. And that's for many reasons. The first one, that these patients can having a lot of carcinoid features, including diarrhea, flushing. And diarrhea may seem something simple, but actually it's not. It's really affecting our patients' daily living. So to have the nutritionist with you from the day one to balance between getting a very proper nutrition, especially in this challenging time we are living right now, to boost your immunity, and also maybe avoid some type of food which can give you a carcinoid features. I think it's a very important point to have this meeting with the nutritionist from day one. And that also can help you with the weight loss. So the weight loss may be not only, Patricia, due to the Lanreotide. I think there's many other factors need to be addressed, and definitely can improve your weight and improve your nutrition that you are having right
Awesome. Thank you. And Patricia, I hope that helps, but I did want to let you know that we actually featured on the Facebook Live series last month, Leanne Burns, who is a nutritionist for the NET community. So I would suggest if you go to the Facebook page, which you're already on, and to the tabs on the left, there's a tab that says, they say like post photos, and there's one that says videos, and that'll take you to our whole bank of videos, and you can see Leanne Burns, who was a couple Facebook Lives ago. And there's going to be some great information in there for you to find your own nutritionist. And she gives out a lot of advice too. So hopefully we can help answer any of those questions that Dr. Mohamed was alluding to. But I agree, knowing the right kind of nutrition for this disease specifically is crucial.
Sure.
Okay, so moving on, anything to add to that, Dr. Mohamed?
I think that's mainly, as we talked in the beginning, to have a multidisciplinary team, including nutritionists, is critical for our patients.
Absolutely agreed. Okay, so next question is from Patty. Again, it's about lutetium-177 or Lutathera, PRRT. Patty says, what happens when you have had the Lutathera, the PRRT, and every time you have a PET scan, the dotatate shows up, making it look like your tumors are growing faster than they really are? Does that make sense?
Okay.
Are you able to follow that?
Yeah, that's a great point. That will bring us to the guidelines of the NANET, the North American Neuroendocrine Tumor, and the Nccn Guidelines. When should I get the imaging? During my treatment with Lutathera. Lutathera is a treatment we give it every 2 months for a total of 8 months. All the recommendations that if the patient does not have any specific clinical symptom which is abnormal, suggesting of progression, you should get the restaging imaging after you finish the 8 months. We usually do it about 1 or 2 months after the last treatment, the 8 months. So what type of imaging should I get? I think the more anatomical imaging, including CT scan or MRI, is definitely the recommended type of imaging, because really you can measure the disease. The gallium-68 is more like a functional imaging. We do it to have idea about the intensity of the somatostatin expression, but also we can consider it if the patient have a CT scan or MRI with equivocal findings, some concerning that we are not sure about it, we can consider doing a gallium-68. So if her question that she did a gallium-68 after they finished the 8 treatment and she found some progression, that would be very concerning, and they will go ahead and get the anatomical imaging. But if you do it in between or very near to the last treatment, it's very common to see something called a pseudo-progression or pseudo-tumor flare, which is basically can be an edema or swelling of the tumor because of the radiation effect. And that's why we don't get this imaging in between the treatments, because it can give you a false impression that your cancer is progressing, which it is not. But if you get a gallium-68, and again, we're talking about the receptor, and you found the receptors more intense, it can be concerning at some point, because the edema or the swelling should not have the receptors. So if you have more receptors with increasing the size, I think it's very reasonable to talk to your oncologist, especially if you have some clinical symptoms, to do anatomical imaging, CT scan or MRI, to see if there's real progression or not. So the bottom line in that, don't get any gallium-68 in between your injection. You finish the 8 months, and then after that, you follow with your oncologist for anatomical imaging, including CT scan or MRI. If there is any concerning finding or equivocal in the anatomical imaging, we can consider gallium-68 at this time. Pseudo-progression or inflammation or edema because of the radiation effect can happen and can give you a false impression that the tumor is progressing, which in reality it is not.
Outstanding. Thank you so much. You explain things so clearly. I really appreciate that, and I know that people do as well. So thank you.
I'm glad that I make it simple.
Yeah, it's good. I mean, it's tough sometimes when you're in a very specific field, like a medical field. It's challenging sometimes to explain it for people like me to understand. So I appreciate it. Okay, moving on. Pamela asks, Are changes likely to become apparent when receiving general anesthesia with or without the protocol when you've reached the 20-year mark?
Okay. It's a slightly complicated question, I think.
Yeah.
So if you're talking about if 20-year mark, I assume that she is in surveillance, maybe. and she already had a surgery for removing her cancer, and now she's 20 years out of her cancer diagnosis, which means she is cured of cancer. Most likely the cancer, at this time is very rare to come back. And most probably the patient now does not have any carcinoid features. So why are we using a protocol under anesthesia for going surgery or procedures? Because some patients with neuroendocrine tumor, if they're exposed to any kind of a stress, whether infection, procedures, or some specific surgery, they can have what we call carcinoid crisis. Basically, flaring of the carcinoid syndrome with a lot of, can be fatal sometimes symptoms. So we use what we called bolus of octreotide injection or drip of the octreotide injection before and during the surgery to prevent this carcinoid crisis. But if the patient already has been treated 20 years ago, they removed the cancer, there is no any cancer left behind, which most probably she does not have any carcinoid features. I don't think there's a lot of evidence for using octreotide bolus shots or drip during the surgery 20 years after you had your surgery.
Great, thank you. Hope that helps, Pamela. So next up, we have a question from Barney. And Barney asks, if a midgut tumor has spread to the liver and has caused carcinoid syndrome for over 2 decades, will the hormone imbalances persist after all tumors have been removed? Does the immune system recover?
It depends on the type of the treatment that you got. So if the patient have midgut neuroendocrine tumor with liver mets, and they have carcinoid features. If these patients, again, this patient, even with metastatic disease, and this brings us to the same point, is the stage most important point in neuroendocrine tumor? And the answer, no. There is another thing which is very important, like grade and differentiation. So if you don't have a lot of tumor pulse, and we will be able to give you treatment and do the surgery for what we call cytoreduction or remove most of these tumors, I don't think that a long time after you heal from the surgery, you are not immunocompromised. Getting the hormonal symptoms because of the disease, especially if the patient having liver metastatic disease, there's a lot of options we can use to control at least the symptoms and to control the disease as well. Again, PRRT or Lutathera is one option if you have a lot of somatostatin expression. Liver-directed therapy is a very good option. And again, liver-directed therapy, a lot of patients is really hesitant during this time because some of them need to stay in the hospital overnight. I will be exposed to a higher risk to getting COVID-19 and all that. And that's, again, discussion between the intervention radiology and the patient for what types of risks. But definitely liver-directed therapy is a procedure that we use all the time to control the disease in the liver, and hopefully will control your carcinoid features as well. Most of the patients after the procedure, they are not immunocompromised. If this is a question, I will be immunocompromised after I get the surgery or the liver-directed therapy. If you're healing well, if you have the average risk factors, I don't think the answer will be yes to these questions. It's different from one case to another, but you are not going to be immunocompromised from having surgery or from having liver-directed therapy if you don't have a lot of other comorbidities and old age and immunocompromised from other treatments.
Got it. Thanks. Okay, Barney, I hope that helps. Next up, Dr. Mohamed, we have a question from Kenneth. And Kenneth asks, after 10 years of following up and doing okay, should you still do the 24-hour urine test from time to time? And let's talk a little bit about what the 24-hour urine test is and what it's used for.
Sure. I think this opens even a more big picture of what lab work the neuroendocrine tumor patient should have. Mm-hmm. A lot of patients coming to me, for example, with a very high chromogranin A and other hormones, and urine, 24-hour urine as well. 24-hour urine is a test that we use to measure the 24-hour serotonin metabolite, something called 5-HIAA, in your urine. The serotonin is basically fluctuating in the 24 hours in your body. If I get serum serotonin, sometimes can be different during the time of the day. And that can be sometimes not really specific for some patients. So we get the 24 hours to make sure if you're really having elevated serotonin, I can see that on the test. Who should get the urine test? If you have basically carcinoid features. If you have a lot of diarrhea, flushing, that's mainly in the patient with the small bowel and some extent the bronchial carcinoid as well. They have these carcinoid features, and we go ahead and we get the 24-hour urine. And most probably this will be the lab tests that I'm going to follow my patient with. If the patient doesn't have a carcinoid features from the beginning, usually I don't get the test. We usually do the surveillance for up to 10 years. Again, when we talk about 10 years here, we talk about the patient has localized disease, they got surgery, and they get cured from their cancer. Usually we do some blood work and we do an imaging. In the first year will be about 3 to 12 months after the surgery. And then after that, we space it out every 6 months and then every 1 year up to 10 years. After 10 years, there is very, very little evidence that the cancer will come back. Yes, there is some risk still, but it's not as within the 10 years after the treatment. So usually I will not get a urine test and imaging in this patient, except if they have some clinical signs indicating that I should be concerned about the cancer coming back or having more carcinoid features. This is for the urine test. How about for the chromogranin A? A lot of patients come to me after the surgery for the chromogranin A really elevated even before they had the surgery. And I keep discussing to them, chromogranin A is not a very good specific tumor marker for neuroendocrine tumors. So I don't really follow up even with that. Sometimes I get it as a baseline, but I tell the patient, this tumor marker that's affected by a lot of type of foods and medications that can make it up and down. So it's not a good tumor marker. My endpoint for chromogranin A, do not follow up with that after the treatment. It can be really confusing and stressful if it's getting higher than normal for the patient, which is really they don't have any disease at that time. And after the 10 years, I don't think there's any evidence to follow up with the chromogranin A. The same with the urine 5-HIAA. If the patient have normalized urine 5-HIAA, no carcinoid features, cured from cancer, having the 10 years, no evidence to follow that after the 10 years.
Got it. Thank you. Okay, everyone, we have about just shy of 20 minutes left, so we still got some time with Dr. Mohamed, so go ahead and get in your questions. I just wanted to reiterate that if we aren't able to get to your questions or you need further information about, your questions, reach out to us at Carcinoid Cancer Foundation here on the Facebook page. You can send a message or you can visit the website at carcinoid.org. And if you haven't noticed in the comments, we've got a team on the back end. Shout out to Grace, who is the machine that keeps CCF running, is doing her best to send links to some of the things Dr. Mohamed has mentioned while we're going through the Facebook Live. So look through the comments and you can see some links that will direct you to more information about some of the topics we've already covered. And we'd have time, about 20 minutes for more questions. So go ahead and send them in. And I just wanted Effie and Beth to know, I have seen your questions about COVID-19 because that's our main focus today. We're in the middle of getting some general questions, but just to let you know, Beth and Effie, we will get back to those questions. So don't go anywhere. Okay, Dr. Mohamed, still hanging in there?
Yeah.
All right. You're doing great, man. I appreciate your time so much. Okay, let's see. Next up, we have a question from Richie. Richie asks, if the cancer has reached the liver and affected the heart, what is the survival rate? Do you know that?
Overall, the patient who having carcinoid heart disease, which is usually about 20% or less, the overall prognosis is not as great. But however, it's different from one case to another. If the patient have an early carcinoid heart disease and we can go ahead and send them to our surgeon and hopefully replace the valve, I think this patient will have a better outcome comparing with other patients who have a terminal carcinoid heart disease. But if the patient having only liver mets without carcinoid heart disease, so it depends also in the grade, it depends on the differentiation. So a lot of factors. We can give a general outcome without knowing all these factors that the patient has. But usually we know that the patient with carcinoid heart disease does not have a great outcome, especially in the terminal stages. There is some medications now we're using to decrease the serotonin, which is the main hormonal or bioactive material, basically going to the right side of the circulation and affecting the valves of the heart. This is how we get carcinoid heart disease. There is some medication to hopefully decrease that, including somatostatin analog. It has been proven to decrease the serotonin level. There's another medication which is called the telotristat or Zermello that we're using also to decrease the serotonin level. There is no any big evidence right now that any of them will prevent carcinoid heart disease. We have a couple of trials now. We are waiting for the results. But I think that the main point on that, it depends on what's your grade, what's your stage, what even the stage of your carcinoid heart disease. And this brings us to the main point. The importance of having a cardiologist know what is carcinoid heart disease is critical to be in this multidisciplinary team for treating your neuroendocrine tumors.
Mm-hmm. You all see that we keep coming back to that main theme, like Dr. Mohamed said. So that's, if there's any takeaway today, I think that's it so far, is like to get the best results and options for this. Try to work with a team, and I've learned that by working with this disease too. It's so important to have that team working together to understand the best path to take. Okay, Sharon asks, I was diagnosed 3.5 years ago with metastatic carcinoid. Now I've started to have the rash, the flushing on my face. Is this normal after so long, after 3.5 years? Does the rash come and go?
So the rash is one of the common manifestations that we see in our neuroendocrine tumor patients. We see it sometimes even more with the pancreatic neuroendocrine tumor versus the carcinoid, the small bowel. And specifically in patients having what we call glucagonoma, which is a tumor producing the glucagon, and these patients having what we call glucagonoma syndrome, and they're having a lot of rash coming. And most probably they're presenting with that. But other neuroendocrine tumor mainly coming with flushing and diarrhea, especially the small bowel. But sometimes we're seeing rash as well. One of the things that we do here is that sometimes a patient having rash, specifically also in the scalp with hair loss, I can order niacin, and this is one of the very important things for neuroendocrine tumor, that some of them having niacin deficiency. I have actually a couple of patients, and our nutritionist was helping us to increase and boost their oral intake and improve their food that they're having every day to hopefully improve any vitamin deficiency, and giving them niacin supplements actually really helping them with the rash and the scalp rash that we can see sometimes. So I think it's many factors. What type of neuroendocrine tumors do you have? Is it due to the glucagon, hypersecretion of the pancreatic neuroendocrine tumor? Is it due to the coming manifestation with carcinoid features? Do you have any attached vitamin deficiency with that need to be treated? So all these factors need to be coming together. Yes, sometimes we don't see it in the beginning and we're seeing later on. So it's one of the common manifestations that I see it with a lot of neuroendocrine tumor patients. Involving your oncologist and investigating other reasons for the rash is very important to know if you need any vitamin supplements. You need to improve your oral intake with your nutritionist. It's very important and critical for your case as well.
Perfect. Very thorough. I appreciate that. Next question, Dr. Mohamed, is from Stacy. And this is a question I actually hear a lot recently. Stacy asks, is there a hereditary element with NETs? Is this genetic that you know of?
So mainly pancreatic neuroendocrine tumor definitely associated with some genetic syndromes, what we call the MEN type 1, which is multiple endocrine neoplasia, and also VHL and tuberous sclerosis. So there's a lot of genetic manifestations, mainly with the pancreas neuroendocrine tumor, not as common with the small bowel or the lung. However, some lung and thymus neuroendocrine tumor also associated with genetic predisposition as well. So one of the things that you need to know, if you're coming with neuroendocrine tumor, you have pancreatic neuroendocrine tumor, and you know what type of that, or we have thymus neuroendocrine tumors, and you are younger age, having family history, it's very important to ask your oncologist from the day one in the visit that you need to see the genetic team so they can run the appropriate test and we know what's going on from the beginning.
Outstanding. Thank you. Okay. Let's see. Patricia asks, should a patient get a CGA test every month? That's chromogranin A? Is that what? Yeah.
The chromogranin A, that's correct. Yeah. So we just talk about the chromogranin A. I don't believe it's a very good tumor marker. There's a lot of factors really impacting the results. I don't think we have a very good evidence that they associated with progression. So my take home point on that, I don't do it for a follow up. I don't think you should have it consistently like that. And even if someone do it, definitely you shouldn't have it every month. If you're doing the follow up every 3 to 4 months, some physician is still ordering that. But if you order that, you need also to prepare an answer for your patient. If it's coming very high, and the scan on the other side does not show any disease progression, and the patient clinically are doing well, I think would be a very reasonable question to ask. So my answer on that, no, you should not have the chromogranin A every month, and it's not a very good tumor marker to keep follow up with.
Great. Point taken. Dr. Mohamed and everyone listening, I'm going to pivot back to just a couple of COVID-19 questions because that's our main priority here today. And because we have about 10 minutes left, and then we'll go back to general questions to finish out. So Dr. Mohamed, Effie asks, have any of your patients, specifically lung dipneck patients, been placed on disability during the pandemic? She's an elementary teacher, and she's curious about returning to work.
Okay. So what is dipneck? Dipneck is a diffuse idiopathic pulmonary hyperplasia, very complicated medical term, which means basically the neuroendocrine cells in your lung start growing, but they did not form a neuroendocrine tumor yet. They can progress to mainly the typical or the lower grade well-differentiated neuroendocrine tumor at one point. Most of these patients having some symptoms similar to COVID, coughing, wheezes, some, like asthma features, that can be concerning for the patient. And even if they come for the cancer center and they tell the screening team that I have all these symptoms, I think would be concerning for everyone. So this will come to the symptom similarity. When it comes to the treatment, most of these patients do not have any immunocompromised treatment. We put them on steroids, bronchodilator, which medication to keep open your airways to help your breathing, but you are not in chemotherapy, even, very rare to use somatostatin analog in this patient. We still can consider it at one point, but we don't usually use it from the beginning. So you are not immunocompromised to put you at higher risk of getting coronavirus. But you are having symptoms which is very similar to the coronavirus symptoms. And if you get COVID-19, you may have a slightly higher risk of complications. Yes, we agree with that. So overall, if the patient is stable, does not have respiratory symptoms, I usually tell them, if you are living in a state not really a hot spot and everything is getting better, I think it's very reasonable to go to work, take all the precautions, always wear the mask. We have a very good literature just maybe a week ago about the importance of mask in the public gathering, and really very important for everyone to wear a mask to prevent the infection transmission from one person to another, because a lot of patients do not have any symptoms outside and you can get infected from. Even when you go to your work, wear the mask, use the hand sanitizer, clean your hand, for more than 20 seconds. I think you will be fine if you don't have a lot of symptoms to go back to work with all these precautions. Depend on a discussion between you and your oncologist.
Got it. Thank you. Hope that helps, Effie. So Beth has a question, and we've already kind of touched base on this. Essentially, if you're a net patient, you're not higher risk of getting coronavirus, but you are at higher risk potentially of complications. And this is what she's concerned about. Beth is really feels like she's high risk for COVID-19. She's had a splenectomy and also have Cushing disease and diabetes. So a lot's going on, and she's concerned. And this is the final time we'll mention this. Are there any extra precautions someone in Beth's situation can take at this point, or is it just abide by the typical guidelines for everyone?
Sure, Randy. I think that's a great point. Specifically, the splenectomy is the type of surgery is going to put you at higher risk of COVID-19. Splenectomy, or removing the spleen, which is very important for fighting a specific type of bacteria called a capsular bacteria. And that's why patients get vaccine after they have the spleen removed. They put risk at this type of infection. There's no any evidence they put you at higher risk of getting coronavirus or COVID-19. So getting the surgery and healing well from that and maintaining your vaccine scheduling and having the general precautions of physical distancing, cleaning your hand, will put you hopefully at the average risk. If that's having more comorbidity, including diabetes, cardiovascular problems, older age, I can phrase it by the way that it will put you at higher risk for getting complications from COVID-19, not necessarily getting COVID-19 infection. So again, I don't think there's a higher risk if you're not immunocompromised. Putting in context together with a discussion with your oncologist what other comorbidities that you have that can put you at higher risk of getting complication, not getting necessary infection with coronavirus.
Outstanding. Thank you. Next up, we'll pivot back to the general questions while we have just about 5 minutes left. Hopefully we can get to a few of them. Dixie asks, and shout out to Dixie, I like that name. Do you still recommend Octreotide or Landryotide shots if progression continues with not many symptoms after many years on the shots?
Okay, that's a great question. So when we should continue the somatostatin analog injection after the progression? If the patient has symptoms, very reasonable to continue the injection. You give it to improve the symptoms, but you are going to add another treatment according to what type of treatment the patient is eligible for. If you have somatostatin expression and they are well differentiated, PRRT or Lutathera as a second line. Again, we have another targeted therapy including everolimus, Afinitor, or sunitinib as well. If the patient does not have symptoms to start with, and I was giving them the somatostatin because only to control the growth of the tumor, it's very reasonable to hold on the treatment and just switch to the second line of treatment. We don't have a very good evidence or trial to comparing if continuing the somatostatin analog, even after the first line, will improve the progression-free survival or not. Hopefully at one point we'll have something like that. It's hard to make a randomized trial like that. So we don't have a lot of evidence of the asymptomatic patient who does not have symptoms that they have any benefit from continuing the somatostatin analog after the first line, after they progress after the first line.
Got it. Thank you. We just got a question in from Linda. Linda asks, is it true that if your NETs metastasize to your liver, ovaries, bones, or pancreas, that you can't have the tumors removed? Is that true?
So metastatic disease in general, sometimes they are not surgical candidates. However, the multidisciplinary discussion of every case, of every single case, is very important because you should have a good surgical oncologist who do a lot of neuroendocrine tumor surgery. He will be able sometime to do what we call cytoreduction, remove as much tumors as they can do, and even ablating, a lot of ablating, which basically using like some burning techniques or to kill the cancer cells in the liver. And they can do that during the surgery as well. So it depends. If the patient has diseases everywhere, liver, bone, in addition to the pancreatic primary neuroendocrine tumors, the answer would be, I don't think it's really reasonable to go ahead for surgery because removing even the primary tumor by itself, it's an area of debate. It's really improving your survival or not in this case. If you only have a primary neuroendocrine tumor in the pancreas and maybe only some liver lesions, we need to discuss very carefully how tumor burden, how many of them you have. You have a couple of liver lesions or 20 liver lesions. Can we go ahead and maybe sometime using a neoadjuvant chemotherapy to shrink this cancer and then go for surgery after that? So it depends. If you have a widely metastatic disease, I think the answer is no, you're not a surgical candidate. If you have less tumor burden with a very specific limited metastatic disease, very reasonable to discuss that in the tumor board and make sure that surgery can be an option either from the beginning or down the road after you get some type of treatment to shrink your cancer.
Got it. Thank you. So we have a question from Stacy, which I really like to ask myself to a lot of doctors that I interview. Are there any treatments in development that you're hopeful about, that you're excited about, like coming down the pike?
I think we are very lucky as neuroendocrine tumor specialists to live in this time of seeing progressing of the treatment options every day. When I look at the medical treatment for neuroendocrine tumors, I can categorize them in 3 treatments. The somatostatin analog, which we have a great symptoms control, we lacking in the response. We have targeted therapy, everolimus, Afinitor, and the sunitinib. We have also the PRRT treatment. So how we can improve every one of them? Now we attach it a radioisotope, which is the PRRT or the Lutathera, to the somatostatin analog. Now we're having different radioisotope in progress in clinical trials. One of them is very promising. So this is one of the new treatment hopefully will come in very soon. It may take some time until we have a phase 3 trial, but it's very promising using a different isotope other than the Lutathera or the lutetium-177, which is different radiation rays basically that we're using. But also attaching other targeted therapy and chemotherapy with the somatostatin analog, which hopefully will help also to improve the response. There's a couple of clinical trials. When we look at the targeted therapy, Now we're having some clinical trials using immunotherapy in addition to targeted therapy. Unfortunately, we did not have a lot of success using immunotherapy by itself in neuroendocrine tumors, but using some targeted therapy because these neuroendocrine tumors are very highly vascular. So using immunotherapy with them, showing that they reprogramming what we call the tumor microenvironment. And hopefully that will also, a couple of trials we're still waiting for the results as well. There is another targeted therapy which basically target again the vessels and target something else called a fibroblast growth factors. It's going, far behind now in China. I think it will be approved very recently, and we're having some early clinical trials here in the US. So improvement in targeted therapy, improvement in radioisotopes, combining chemotherapy with the somatostatin, which the biphasic, combining immunotherapy, and even combining some of these with the PRRT. We're waiting for a great, I think, outcomes during the next years, hopefully, for neuroendocrine tumors. So we'll have a lot of options.
Outstanding. Thank you so much. I think that's a great place for us to end today. But before we go, everybody, I just want to say that we got a lot of questions in there kind of in the second half of our program today and we, unfortunately, weren't able to get to all of them. But I want to reiterate that one, feel free to follow up with Carcinoid Cancer Foundation here or at their website. But a lot of the questions that I'm able to see right now, we have content out there that we've addressed. CCF provides a ton of all free content in their blogs, in their video content that we help them create. So if you go to the video tab on their Facebook page, for instance, we've done Facebook Lives on carcinoid heart disease. I see there's some questions about that. We've done Facebook Lives on nutrition. I see questions about that. So do me a favor and comb through some of the videos that we've already done, because chances are we may have covered that already. And if this Facebook Live that we've done today or any other ones are helpful, or you think they would help someone else, do us a favor and share those. If you look right now at the screen you're watching, right beside comment, there's a button that says share, and you can share this to anyone who you think would need to hear it on Facebook. And if we have done a good job for you today, send us a thumbs up, send us a heart emoji. There's even a new one of emoji hugging a heart, showing that we care for one another. That's one of the things I love about this community is everybody seems to be fighting for each other. I really like that personally. Thank you, Dr. Mohamed, for your time. You were excellent. Sure. I don't know if you've been media trained before, but man, you are really great at doling out information so that it's understandable. And so I as a storyteller and filmmaker, appreciate that so much.
I really appreciate getting me today, and hopefully will be helpful to all our neuroendocrine tumor patients at any time.
Absolutely. And to all of our audience members and attendees, we appreciate you spending this time with us today. We hope we were able to answer some of your questions. Follow up with us if not, but we also have video content on YouTube and a lot of stuff out there that hopefully we can answer your questions. And as always, thanks again majorly to our presenting sponsor, Lexicon Pharmaceuticals. There's no way we would be able to do this without them, and we're just so fulfilled and pleased with their support of the overall NET community, and proud to have partnered with them to create this kind of content, because it's clearly impactful for our audience. So we appreciate that. So we will be back next week, everybody, next Thursday, actually. So stay tuned, and we'll see you next time on the Carcinoid Cancer Foundation Facebook Live series. Dr. Mohamed, have a great day.
Thank you.
Everyone out there, be safe, be healthy, and take care of yourself.